So I will have the first talk about the lipids, and I think that's very important that we know that why are we using those intravenous lipid emulsions in clinical practice. And I can share with you up front that we have been doing that for several decades. Lipids are in Europe always a part of what we are feeding, and I will explain you why. So this is what we are doing. Lipids, what are the benefits of daily use? This is what I would like to talk to you. So first of all, ladies and gentlemen, we know now that when you provide the right amount of energy to your patients, you will have an impact on mortality. It took us some years to have this data because in intensive care in the critically ill population, there's so many confounding factors that impact on mortality that to find a benefit, it's sometimes a hard job. But we have those meta-analyses on almost 1,000 patients that show when you use indirect calorimetry to actually know how much energy you will provide, and you do that, you don't give them too much, and you're sure that you're giving them enough, you will have a reduction in mortality. So we have another one, there's another meta-analysis by Petrov 2022. So we have two big papers showing that the amount of energy matters. It makes a difference for your patient. And how do we get to that amount of calories or energy being provided to your patients? This is a paper 2017 by Takuo Shima from Japan. He was in Switzerland at that time. And this is really how we work in our institution, how we work in ICU. The first 1, 2, or even 3 days, we are careful with artificial nutrition because we know that the body will be reacting to the disease, to the treatment, and that there will be some endogenous energy production. So your liver and other parts of the body will be creating and making a lot of glucose, so you can live on that. But it sometimes can be limited to a few hours, mostly or sometimes up to a few days. So in this early stage, what I would call day 1, 2, or 3, but mostly physiology, like your patient, when your patient is stabilized, this is where artificial nutrition comes in. Of course, we would go for enteral nutrition first, but on day 3, when we do the test and we know how much energy our patient needs, we would put on some supplemental parenteral nutrition if needed to make sure we cover the needs. So this calorie target-driven nutritional therapy, that is what we are doing. So we want to be on target because of just the two meta-analysis that I showed you, or I was talking about, where it's really clear that if you give the right amount, then your patients will benefit. Now, this discussion on combining the routes was something that was alive in Europe almost 8 years ago, I think. But the message I want to have here today is that it's the patient who will guide you through the nutritional strategy. If your patient can eat, that's fine. If they need enteral nutrition, we'll do that. If they can't, we'll have parenteral nutrition. And we will also have a combination of the routes. So this is really what matters. For us, the most important thing is that we get the amount of energy and protein that we think is the best for our patient in the patient. And how we get it in there, that's of second importance. You had the calories trial by Harvey, 2014, New England, showing that there's no mortality difference between EN and PN in critical care. So since then, we are just doing like I showed, combining the route to make sure we cover the targets. Now, when we are providing this artificial nutrition, what are we doing? We are replacing normal food. We are replacing the breakfast that we would be having, including some glucose, amino acids, lipids, some vitamins that you can get from the fruit, and the minerals and the trace elements. We are just replacing normal food. And when we are doing that, why do we include the lipids? So because, of course, they're a natural component of food. That is what a body needs. And they have two big advantages when you use them. First of all, the amount of calories that are in the lipids. You know it. You know, when I eat Belgian chocolate, I'm like, oh, go easy. There's a lot of lipids in there. This is high caloric. It's 9 kcal per gram. You know, the other ones are 4. So there's a lot of calories. This is the first line why we like lipids. Secondly, we are providing essential fatty acids. We'll talk about it. And they're only a component of the lipids. So they are a part of normal food. So this is a small illustration where I wanted to point it out indeed that you have two layers of why we feed with lipids. You meet the caloric intake requirements with a limited volume. You know, they're very dense. So for our patients who don't have to or cannot tolerate a lot of fluids, you know, you cannot give them 2 or 3 liters. We will give them 2 liters of IV food. And when you have lipids, you have a higher calorie content. So that's the first important message. And sometimes I wonder in those high BMI patients, how would you do that without lipids? How do you get to that amount of calories if you don't have the lipids? And then secondly, you will see non-essential fatty acids. We'll talk about it later. So for this caloric intake, that is also why for a long time it has been in our guidelines from the European Society of Clinical Nutrition and Metabolism in Europe. I was an executive member of that society. And you can see here in the middle bar that the administration of intravenous lipid emulsions should be generally a part of PN. So that's just it. It should be there. That's actually what it states. When you go to the ASPEN website, there's free download of the guidelines. You can see the whole rationale behind that. So there's an explication, of course. And there you can also see that we have a strong consensus. What doesn't always happen when you put a lot of experts together. But we are sure about that one. So for us, it feels natural. It's what we do, what we'll be doing for a very long time. Here I listed both of them. So you had the ASPEN recommendation, the ASPEN. And we can see a little bit about the difference. Of course, you can also see on lipid intake, we have this amount of how much you would be giving, and I think that here, that's very something that you really connect to because you work with that, with the ratios between the glucose and the lipids and so on. So I'm happy to see that, but you can say that also in our recommendation, you see the dosing, and then in the American one, you also see that you should avoid the soy lipids, and we will talk about that later. So here, once again, American and European guidelines put together. Like I said, lipid emulsions should be a part of PN. They are also a part of EN. Nobody talks about getting lipids out of EN, so okay. And you see there what you can do. The first very important line is also the thing about glucose. You know, we will see that targeting blood glucose is a very important thing. We had big trials also in Belgium being performed on that topic. So, of course, when you can provide lipids, you will need less glucose and your glucose control will be much easier. So that's another additional benefit of using those lipids. So this is, I think, very important. I know that there was an update. So here you can see, and I put a little part of the latest recommendation. Intravenous lipid emulsions is a safe and effective energy source that can be included within the PN formulation at the time of initiation, including the first week. So, I mean, this is what we've been doing for 15 years or so, or 20 years. So I feel very comfortable, and I'm very happy that also for your patients, they will be having this access to the calorie load and to the essential fatty acids. So they will have a complete breakfast in an intravenous lipid form. So in an intravenous form. So I'm very happy to see that. Why do we need the lipids? So like I said, first of all, calorie content. Secondly, the glucose control. Okay, it's a busy slide, but the only thing that I want to have here is that in this recent publication, 2022, in the diabetes publication, they said, okay, what can you do to have an improved glucose control in the critically ill patients? And you can see here that you have a pharmacological treatment, of course. You can give them insulin and even more insulin, and the nurse would go up to you, and we are giving a lot of insulin. So, okay, be careful with that one. It can also be a sign that maybe you have to have a double check on your patient. But the nutritional regimen is also something that they are talking about that can help you in getting there. And combining PN with oral intake and or EN, reducing the glucose content of the PN in critically ill patients. And I like this statement because it comes from diabetes world, so they're just thinking on how can we do it. It's not even a real nutrition paper. So reducing the glucose content, I think this is very important that we have a balanced ratio between what we are doing, being normal food, replacing it in an IV form. So, okay, we saw about the energy load, we talked about the glucose control, and then there are the essential fatty acids. So layer number one is feed your patients. Secondly, we're also acting on something that you cannot see, but it is very crucial to our patients. So I repeat this slide because, like I said, caloric intake is one, but the full provision of essential fatty acids, it's really, really important for our patients. Our patients who are critically ill are fighting for their lives, they suffer, they have a hard time, they might not get there, and they need every building block, they need everything they need in this battle, and it's up to us to provide it. It's up to us to provide it. They rely on us. They are relying on us to give them what they need to have the best chances during this period of acute illness. So this full provision of essential fatty acids, it will be incorporated in the membrane structure, so it will actually change things at a cellular level. It will actually do something that you cannot see but can be of great importance. And we're not gonna go into this. I mean, this is a Sunday morning. Let's not just not do that. But the only thing that I want to point is that they are essential, and they're called essential because the body cannot make it. We need to provide it. We need to give it to them. They cannot produce it by themselves. And this is why you will always also need this linoleic acid and alpha-linoleic acid. I mean, those are the essential ones. Those need to be there. They need to be there. You can talk about all the other benefits of PN and IVL, but this is what they need to be there because we are giving to the patients what they need. When they are incorporated into the cell membranes and into the cellular function, they have different immunotypes. So the mechanisms by which the fatty acids work, they can affect the immune cell function. So this is important because when you go more to a biological and biochemical point of looking at it, we know that what you will be providing will be incorporated into the membranes, but also into resolvins and a lot of other proteins that will act in your immune system. So you will influence the immune system and the inflammatory response. And this is something that's close to my heart because in ICU, you have a lot of patients who are overactive immune response, or they, especially, remember the COVID patients, they had this toxic storm and it was the immune system taking them down. And then you just don't want to mingle with that. You don't want to be there. You just want to feed the patients. So in this evolution of lipid emulsions, there are characteristics. And you will never hear me saying that one IVL is better than the other one. I think they have different characteristics. But from a point of view on working with this inflammatory status, I like always to be a little bit on the safe side. I like to be on the safe side. So you can see an overview. And you have also like the olive oil emulsions. I'm in Brussels. I have all of them. I mean, it's not because I'm here. I have all of them. I can use all of them. But because I don't have good biomarkers in my clinical practice to tell me, now it's a good time to, interfere with the immune system, I prefer to stay on the safe side. And I provide around 97% of olive-based lipid emulsions to my patients. Because like I said, and this is a little bit complimentary publication by Dan Weitzberg, there are on the second layer, you have different actions. But I am really missing good clinical guidance to use it at this time point. Maybe in the future we will know today is going to be a good day for this one and tomorrow is going to be a better day for that one. But at this time point, we don't have that guidance. So I prefer on the safe side, and I really want to be where we are on a neutral side. I don't want to interfere with the immune system if I don't have good guidance. So this is my message there. Now, so I told you that we use lipids all the time because they provide a good caloric target. You can feed a lot of patients. And secondly, you are providing those essential fatty acids, and your glucose control is much easier. Now, is it all good news? No, of course not. We have to be careful. We are giving something intravenously to very sick patients. So we should be very good at monitoring that, keeping an eye on what we're doing, and adapt our strategies. But when you look into, what are the side effects of the use of parenteral nutrition, including lipids, you immediately fall once again on this glycemic control. And here are some papers that says, okay, when you have some propofol, sepsis, lipid solutions, and overfeeding, you can have hypertriglyceridemia. So this is really what we do in clinical practice. We would do that on day 1. We would do that on day 4 and day 7. And also outside of ICU, we would monitoring that at the beginning, after 1 week. And in our chronically patients, we would also monitor that. So that's something that will really help us on saying, okay, if it's above a certain level, be careful and don't go too high. Maybe stop for a day, redo the lab, and then start again. So, of course, and this paper by Mette Berger is a very good paper. If you want to feel reassured about the use of your artificial nutrition, it's a really nice paper. Now, I want to show with you some of the work, but I have to tell you, it's really brand new, and it's not been reviewed, so please interpret with some caution. We were actually also thinking about this question in Brussels, because it's not such a big issue anymore. We had one surgeon who didn't want the lipids in his patients. He was the only one. We have 650 MDs. He was the only one. And we even called the bag we made compounding without lipids, and we give it his name, because he's the only one. And then when he retired, he came up to me and he said, Elisabeth, thank you for doing that, because I know that we agree not to agree on this point. He said, but you know what? With these new intravenous lipid emulsions that you have, you just don't have the complications that I used to see 30 years ago. So probably I should have stopped doing that 10 years ago. I was like, okay. Okay, go away. But on the other hand, it was nice to see that he could change his opinion, that he learned from our experience, and that he said, like, okay, this was something from way back. We are not seeing that, so I would actually advocate to change. So here, risk and complications. We were looking at what is the strength of the use of parenteral nutrition in liver test abnormalities, because we would also go on rounds, and then there would be a doctor, oh no, but I have a disturbed liver function test lab here. I don't want to feed the patient because maybe it will make it worse. So I have a very good clinical pharmacist who's doing her PhD on that, and she looked into it, and what you see here with the red bars, that's modeling. So she's looking at parameters that are contributing to disturbed liver function tests. And we took hepatotoxic drugs that are very common in ICU. We took acute illness. And what you can see, for example, in one of the liver function tests, this is AST, you could see that acute heart failure and the fact that you already have a disturbed liver function test when you give the nutrition, those are the most important compounds or parameters that will influence the change of the liver parameter set. And the use of PN and even the volume is very limited, very limited. On ALT, it's even more limited. We showed it to a hepatology, and he said, okay, that's nothing. But that's very important, because this means that you should be looking at your patient, and when the patient has an acute heart failure, with backward failure, or liver disturbances at the start, this is a patient that you have to keep an eye on. But all the other ones, you can just provide them, and even this population, it's not the lipids, it's not the parenteral nutrition that is going to contribute in a big way to the changes of liver test abnormalities. I think when we will be able to publish that, it's going to be a very relevant clinical discovery. Second, here what I wanted to show, so we looked into our own data, and we discovered that actually we were feeding our patients well. And when those numbers come out of your Excel file, you feel reassured, because that's what we do every day. So the bottom bar is a calorie load per day, and we are within the 20 to 25 kcal per kg per day. So we are nicely feeding our patients in ICU. But in the other three bars, we saw that we were giving too much glucose, not enough lipids, and not enough proteins. And those data went up to 2019, and we changed them. At that time, we were going down on the glucose, going up on the lipids and protein. So we changed the products in enteral and parenteral that we were using, and we started on day 2 or 3 with a PN if necessary. So now we will do the test again, and the glucose that we give to the patient has gone down. So it led to change, it led to improvement. It's very important to have this data. So the risk and the complications, once again, another paper here from 2020, where we see that PN-related factors include continuous PN infusion, excessive glucose intake, and use of soybean. I think that kind of wraps it up. I mean, this is really what we know, what we saw in our own data, what we know from literature, and why we are having the approach that we are having right now. So I think that I might want to conclude my part of this talk by saying that, first of all, when you provide lipids right from the start, like it is advocated in the guidelines and the recommendations, you will have a much easier time providing enough energy that will change the outcome of your patients, that will have a reduction in mortality. You will be there, and you will do that in a more balanced way. So we are just replacing food. We have to, feed what they need. And what is normal food, we are replacing it. And we are replacing it intravenously, and you can get to a higher amount of calories when you have these 3 components of your nutrition. It will bring down hyperglycemia, you don't have to go so heavy on the insulin, and it's just more balanced. We cannot live on sugar neither. You can do it for a few hours, but then you would need something else. You are providing essential amino acids. You are actually giving to your patients what they need in their combat against critical illness or in chronic situation. And it's recommended. I mean, we feel very... We think it's very important that your protocol in your hospital or in your setting is based on guidelines, because you can change every week. There are no new publications and so on. Just don't do that, because you have a whole team of people. You have your dietitian, your nurses, your colleagues. And we say, okay, when we are doing or when we are suggesting this for this patient, it's not me. You don't have to do it for me. It's because it's in the guidelines. It's because a lot of people took time to do meta-analysis and put guidelines together. So that's the way we go. And they're in the guidelines. Lipids are there from the start. And of course, you have to monitor, as with everything that you do in this frail population. You have to monitor, you have to be careful and look at your patient. But in my experience, when you have this monitoring in place, this is really the best strategy that we can offer to our patients. So thank you for your attention.